Assalamu alaikum. The long clinical consultation day. First scenario, 75 years old male presented with hoarseness of voice to the neurology clinic. Patient on wheelchair. Vitals are within normal. Please take history, do examination, and address the concerns. Ready?
Yes.
Yes, here you go.
Hello, I am Dr. Muhammad. I am one of the doctors here today. I need to confirm Mr. Farouk, 75-year-old with me.
Yes. Yes.
How are you, Mr. Farouk?
I'm fine. I'm fine. I've just been
Yes.
noticing some changes in my voice in the last 3 or 4 months, and um, I've been referred by the GP to see you.
Sorry for what happened for you, Mr. Farouk. I need to know more about this, what's happened to you. This source of voice started gradually or suddenly?
It started, I think gradually, yeah. It's the voice changes, yeah.
Okay. You notice it increase by time?
Yeah, you can say, yeah.
Okay. The same morning as evening or night or different by
Yes.
time same day?
No, it's there all the time. There is no difference.
Sorry for that, Mr. You
It's not
notice anything?
significant. It's not that significant, but it's still there. I can recognize that my voice has changed, but yeah.
Sorry for that. You notice anything in the daily activity all over the day? You feel it increase, improve it, or
No, no.
no? Okay. I need to confirm any shortness of breath with it.
Well, no. There is no shortness of breath, but I usually snore when I'm sleeping, and I wake up usually also from that.
Sorry for that. You feel any headache after awakening in the morning?
No, 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 no.
You notice in your weight changed the last few months?
No.
Okay. Again, any problem in your swallowing food or
There is some choking. Thanks for reminding me. Recently, I also felt that it's difficult to handle such food. The food stuck in my throat.
so your feeding changed or affected the last few 4 months, right?
Yeah, but honestly, the choking has been there for like 6 to 8 months.
So the shopping started earlier.
Yeah,
Okay, sorry for that. Or also suddenly or gradually?
I believe gradually. Yeah, not all of
Okay.
a sudden. No.
I am seeing you in wheelchair. Can I know more about that?
It's probably because of the age. It helps me to go to the shopping and stuff because my legs are weak. But it's been there like um for quite two or 3 years.
Okay, Mr. Farouk, I need to know more about this, the weakness. Any diagnosis for it last 3 years before? Any
No,
trauma, anything?
no,
No diagnosis. You didn't hospitalize for that or follow up with
no,
any doctor?
no, no,
Okay, so you can't stand up now, right?
no.
Okay, okay, sorry for that. So it started gradually. This weakness in your lower limb started gradually.
Yes, it's been there in the family also as well. So it's not surprising for me. My brother had the same problem, yeah.
Okay, sorry for that, Ms. Farouk, Mr. Farouk. Okay, can I know more? I asked about your weight. Any changes, decreasing, increasing? You confirm me.
There is no much change in my weight, to be honest.
Okay. Any problem in when you're doing combing in your to your hair or raising something object up?
It's usually I can't do those liftings, but yeah, there is that you can say that there is some weakness, yeah.
Okay. You notice any lid dropping or your face changed nowadays? Separation?
No, but there is some um uh twitches around my mouth
Yes,
that I have
around.
noted. Yeah.
This is since when?
I don't remember when it started, but I noticed it recently. Yeah.
Okay, okay. It is increasing. Any other twitches in your body?
Not that I'm aware of.
You don't know. Okay. Any other preferences?
No, no,
Okay. Any other weakness, any part of your body?
no.
Any changes in sensation in your body?
It's difficult to tell. But I honestly, I don't use my feet that much, so um, it could be, but honestly, I don't know.
Okay. Any vision problem?
No,
Any hearing problem?
no,
Any dizziness?
no. When I'm sitting, no,
Any changing in your mood?
no.
Okay. Can I know any past medical history apart from that family history of that weakness?
It's
Diabetes, hypertension,
uh
anything?
no. It's just I've been visiting for years the fertility clinic, but it's nothing they could do about that. Um,
Okay. يعني no children or no chance. Sorry for that, right?
there's no children. Also, my brother had the same problem, and there is no children. No.
Sorry for that. Any other family history?
Any other family history? No.
Any allergies?
Any allergies? No, 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 no.
Any procedure or operations?
No, no,
Okay. Any travel history?
no,
Okay. Any blood transfusion?
no.
Any sorry for this? Any illicit drugs?
No, 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 no,
Okay. Any casual relationship? Sorry for this question.
no,
Okay. Any piercing, tattooing, anything of this?
no,
What's your job, Mr. Farouk? Any job?
no. I didn't. I stopped working for the last um 2 years, but or 3 years. Before that, I was in a cashier in a supermarket.
Sorry for that. Any support you need, we can share our occupational health, okay? Clinic.
Okay.
Any driving?
No, not at the moment.
Okay. Can I see the patient, please? Any picture for him?
No, there is no available pictures, but the patient is in a wheelchair. He is sitting. Do you want to start the examination?
Yes, I need to start the examination.
Okay.
How is the span and height of the patient? Any disproportionality?
No, no,
How is his tall?
it's not measured.
And how is body mass index?
Body mass index is 23.
23. I need to start my examination by full cranial nerve examination. Any problem in smell or
No,
start?
no problem in smell.
I will do full vision from the side
Normal,
and pupil vision field
normal,
movement, no problem. Okay,
normal,
five and seven and eight cranial nerve. I will ask him to raise her brow and closing his eye and laugh.
normal.
Hearing eight nerves. Okay.
Yeah, normal.
Okay. The skull, his
It's
skull is normal size or
it's normal size, and what you noticed is pre-oral fasciculation. It's visible.
okay. Okay. I will do cavustic sign on tap after permission from the examiner. I will tap in his in front of his ear. There is a spasm. Hello.
Chivostic sign? No, no,
It's okay. Cavustic sign.
no. Yeah, it's okay.
Okay. Okay. And Trozo sign also is okay. I will
Yeah.
put the cuff on the. Okay, I will I will check his hand. I need to see any muscle atrophy and guttering of the back of the hand.
There is muscle atrophy, yes.
Okay. How is the bulk of the muscle all over up to up also atrophied?
No, there is an evident muscle atrophy on his hand and his forearm.
You will elect any fasciculation?
On there is some fasciculations on in his medial aspect, yeah.
Okay, I will ask him to elevate his hand up to do and close the hand to do pronator drift. He can.
He can, yes.
No pronator.
No pronator drift.
Check for muscle power around the shoulder and the
Reduced.
elbow. Reduced.
Reduced.
More proximally or distally?
It is reduced distally.
Reduced distally. Okay. Finger nose test bilateral.
He's able to do so, but he's doing it slowly.
Okay. Sensation. Anterior column
There
between
is
the
posterior column is fine. There is some patchy sensory loss, but it's not consistent with anything.
not consistent with anything.
Not
يعني ده-
consistent with the current picture.
So there is
There's some patchy sensory loss, and there's some patchy sensory loss you can carry out. Don't worry.
okay. What about tone and reflexes?
Tone is reduced. Reflexes are are not brisk.
Okay, I will go to the limb. I will do blunter. What about blunter?
Equivocal.
Vocal. What about sensation?
There is some patchy sensory loss in L4, L5 dermatomes, but apart from this, posterior column is intact.
For L5. And by inspection, the bulk of the muscle, how it is?
There is also wasting, yeah.
Wasting. Okay, and reflexes?
Reflexes are as same as the upper limb. It's present but not brisk and
يعني there is hyporeflexia, hypotonia,
hyporeflex. Yeah.
hyporeflexia,
Have you checked?
hypotonia.
Yeah. Have you checked for the tone?
I am asking about the tone
Yeah, the
also.
tone. Yeah. The tone is reduced. Yeah.
Okay, I will
Hypotonia.
ask him at the around to see the proximal weakness at around the hip. He can abduct.
No, you can't. No need to do that. The patient is in wheelchair. You are examining on the wheelchair.
he can't do, or no need to do this.
No need to do this.
Okay, okay. Any alcohol intake?
No. The regular alcohol drinking on the weekends, no more than 14 units.
Okay. Any smoking?
Yes, he's smoker.
Okay. How many? But how many years?
For 50 years. He stopped smoke. I stopped smoking in the last 10 years.
Okay. Any cough?
Cough is weak.
2 minutes
Cough is weak.
left.
No, but no, there is no crackles, upper zone or lower zone.
No, chest is normal.
Okay. Heart is okay. S1, S2. Any adventitial or murmurs?
No,
Aortic area is okay. No murmur.
no murmur.
Any loss of control, bowel work or water work?
No,
Any changes in the bowel work or water work, like fluorescing
no,
urine? Blood?
no.
Okay, okay. What's your concern, Mr. Farouk?
I'm sorry. When you check the chest area, also there is some evidence of gynecomastia.
Okay,
Okay.
okay. I will fix this
No, as
if
yeah.
anything there or any masses or anything. Anything there?
No. It's
Okay.
just gynecomastia. There is I don't have any concern, but I'm just worried. I've never been diagnosed, to be honest. I'm afraid that I would have my brother ended up needing NIV. They call it NIV in the community, and nurses was coming to his house to put him on some to take care of multiple things.
I am so sorry for happening for your brother, but really the first possibility in our mind that maybe the same condition. I am so sorry for this, and maybe also progression can happen in the same way. But we need to do some lab imaging tracing for the nerves and muscles to confirm our diagnosis. When I will
Okay.
come.
Okay. Okay.
Okay.
Any other question?
No.
Okay, examiner questions.
Could you please present your finding and the possible differential?
My first finding looks.
I'm sorry. Just one second. Can you hear me? The voice is interrupting. I'm not sure why.
Yes, I'm hearing you.
Okay, but your voice is very interrupting, Dr. I don't know. It's the problem is on my side or
No,
or
not from your side. Even from Dr. Abdul it's okay. We can hear you, Dr. Muhammad.
okay.
Huh?
Hello.
Yes.
Yes,
Yep.
Dr.
Yeah, I
Muhammad.
can hear you. Yeah.
Okay. Yeah, I will restart the timer. Please start the questions now, Dr. Omar.
So can you please present your finding and your possible differential?
We have 75-year-old male presented by hoarseness of voice since 4 months back, gradual onset, progressive course was shocking 6 months before. Also, he had a history of 6 years back of gradual onset and progressive course of muscle weakness and become a bit wheelchair bound. On examination, we have a picture of disused muscle atrophy and progressive motor disease, mostly genetic because he has a family history of that with some sensory anterior column affection, upper limb and lower limb, and ended including started bulbar symptoms in picture of choking and hoarseness voice with infertility, hypogonadism, and gynecomastia. My first diagnosis, طبعا I need to see the picture of the patient to help me, but I got my first diagnosis motor neuron disease, but against that there is a sensory affection, chronic inflammatory demyelinating, second differential, third limb girdle muscle dystrophy, fascioscapulo muscle dystrophy, but against that the facial muscle is okay. It's my all differential.
Thank you. So, given the presence of the preoral fasciculation and the gynecomastia and the inability to conceive, should this prompt you to think of something else to add also among the differential?
Pseudo hypopara.
I'm not aware of that, to be honest, but there is those three are characteristic for certain syndrome that also is amongst the group of differential of motor neuron disease, of lower motor neuron characteristic.
It is a subtype of motor neuron.
It's not subtype. It's with the differential usually, and it's characterized by spinobulbar. It's characterized by bulbar symptoms, evident pre-oral fasciculations, and a background history. Usually, there is a background history of what you've described exactly: testicular atrophy, gynecomastia, and inability to conceive.
Not coming to my mind really, but
No worries.
give
No,
me
no.
at the end. I will continue my investigation, and then give us
Yeah. No worries, no worries.
okay,
The next question will be how you would manage this patient.
okay.
Shine some light on investigations and management plan.
Okay, okay. For me, the patient coming with alarm sign of bulbar and hoarseness voice, and he's telling my briefing, he didn't confirm it is okay or not, but he's telling the scuff reflex also not okay. So I first, as per ABC approach, I will do for him. I will check for saturation, EPG, CO2, pulmonary function test to see if he's need any non-invasive support, even up to intubation. Then I will start to him apart from the basic after stabilizing, apart from the basic investigation, CBC, SR, CRP, and CK level for the muscle problem, and full electrolytes, including calcium. I will, for specific diagnosis, I will send EMG and nerve conduction velocity and genetic testing to confirm diagnosis. I will do chest X-ray for any aspiration. I will do also ECG and echo for any arrhythmia there, as a usually association with any genetic muscle problem. I will share as a multidisciplinary team. I will share nerve doctor and a neurologist and genetic and fertility doctor and occupational health, full support for him, occupational and social and physiotherapist, and educate and counsel, and
Thank you.
our fertility doctor to help him regarding if he can conceive.
Okay. You've mentioned that you would like to do nerve conduction and EMG.
Yes,
Do you think in
total
this
biopsy
patient,
and the
do you think in this patient would the nerve conduction would show any abnormality?
nerve conduction, no, it will no problem. It will be in the
Yeah.
electromyogram and the muscle biopsy and the CK.
Yes. 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 Um, One more question, but it would be so the line of questions has finished. The next question would be usually it's asked toward the end. What's the mode of inheritance of that disease? I think Dr. Abdulali, you can answer that from what the patient have told you, even if you
Yeah,
don't know the
his
exact
brother
syndrome.
the same. He was autosomal dominant mostly, right?
It could be X-linked recessive also. So it's X-linked recessive.
And it's linked that is right, right.
Yeah, yeah, yeah. Thank you, Dr. Abdulali.
Okay, are you done, Dr. Omar, with the question?
Yes.
Okay.
Do you want me to do you want Dr. Bassem, do you want to start to comment first or you want me to comment? Okay.
You can start, then I will comment on the performance.
Okay.
However, it's rare case as written in the chat box, but let's comment first, then I will back comment after your comment.
Okay. So
Okay, good,
this
thanks.
so this case is to falls in the differential diagnosis of the motor neuron disease of lower motor neuron picture. And I think in last week we touched based on the types of motor neuron disease, and we usually the differential diagnosis for such a picture, it's MND. Yes, no one would uh, um, tell you not to put in MND with lower motor neuron characteristic as a first. The second would be Kennedy's disease, which is the spinobulbar muscular atrophy, which is an X-linked recessive. A multifocal motor neuropathy with and without conduction block. And you can list all of the differential if you stuck with the examiners for the lower motor neuron picture. Just to refresh our minds about Kennedy's disease, it's an X-linked recessive trinucleotide repeat, usually affect males, and it would have like an MND picture with characteristic preoral fasciculation, tongue fasciculation, and he would have a background of inability to conceive due to androgen receptor mutation in androgen receptor gene also as well. He would have the gynecomastia, testicular atrophy, and reduced fertility. Dr. Abdelal covered it well by adding in his management the genetic counseling.
Yes, Dr. Omar. Yeah, that's it?
Yeah.
Okay, thank you, Dr. Omar, for the case. I think, yes, if we mention that it's type of motor neuron or differential of motor neuron, that's enough.
Yeah.
Yeah, I agree to say
And I
it's
think Dr.
differential.
Abdelal has got it right. يعني.
No, but actually, to know it, as written in the scenario, in the chat box, sorry, it's common in UK. They brought such case. And also in past test. It's a very common case in past test. Particularly when they are mentioning perioral fasciculation. It's like a typical presentation of Kennedy's disease. Let's go to the other differential. What about Friedreich ataxia? If we can add it as lower motor plus upper plus also sensation, but no
But the patient
cerebellar
doesn't
here.
have,
Yeah,
he doesn't have ocular involvement.
yeah, it's not necessary to have all Friedreich ataxia manifestation. But I can see a lot of manifestation and mixture of upper motor, lower motor, plus sensory or sensation affection. So apart from the dorsal column affection, but you can say it's one of the differential. I think you can put it even before the proximal myopathy or myotonia or the other cause of muscular dystrophy,
Yes.
because here there is sensory affection. Okay, let's go back to the comment and to know why Dr. Muhammad, he was confused. Yeah, because he started to analyze the complaint, then the relevant system, then the constitutional symptoms, but some in between, you as a surrogate try to deviate him from the track. But he followed you. When he said family C, he continued. For me, I prefer whenever the patient will tell something away from your track, Dr. Muhammad, you can be back to your track as approach. Then tell him, I will be back to you in this point later on. What you miss here in all scenario as an approach in the history? What do you think you missed? And you ask them at the end. I think this is a frequent and repeated mistake. The systemic review, right?
Yes, yes, Doctor. But I usually leave it systemic review as a
Exactly.
point. Yes.
Yeah. So you
The
don't
problem,
have.
I thought it will be a picture, so
Yes,
I
I know.
after
It's
system, I wanted to ask. I need to see the patient. This is from the beginning, but I need to continue until we see which syndrome. طبعا Kennedy
exactly.
syndrome, I didn't practice it at all. I didn't see at all. It will not come in my mind. Yeah.
Yes, you're right. It's in past test videos. Whenever you see the video of Kennedy disease, you will know this is a case of Kennedy disease. Forget about it, but I want to comment on this part of history. If you miss the systemic review, whenever you are doing examination, you will be confused. You don't know what to examine. Here, of course, you have to do full neurological examination, the sensation, the motor, the pronator drift, the cerebellar, facial nerve, the power, the tone, upper and lower limb quickly. But if this patient is having something in the chest or in the GI or the urinary tract, you might forget or you might miss it. He told you accidentally, I have gynecomastia, or he told you the patient is having gynecomastia. Maybe you will discover it in the patient or no. The fertility also, he was volunteered to say it to you. But it's okay to just to remind each other that you have to follow the approach till the end. Try to, whenever he deviate you,
This is a short case. It is not a long case. That's why it is a
no, it can come. Why not? By the way, it's not necessary to bring such cases as the short, because also you have history
I
here.
need to know. I need to know. Usually, the long cases. I am not against. It's very, very good to practice something. يعني rare
Yes.
or not.
Okay.
But usually, the long case it should be some association and complication to manage and to do them. يعني يعني he should manage. He should test you on your knowledge in long cases.
Exactly.
Even if
That's
he
why
bring any cardiac case, any chest case that can come in the chest, he will يعني do another addition for the case to be more يعني he put a يعني he what you are telling he will take the short case and modify something in it to see the association and the complication and to be more differential like this.
you put good differential, you analyze the neurological part good. Even the complaint here, you analyzed it good. You ruled out myasthenia gravis, you ruled out other cause of the dysphagia. I believe you did get a good in the first part,
Yes.
but the only comment on the systemic review. Okay, you did great in the all case performance. You were about to miss the concern. You spend 1 minute for the systemic review, and uh, later on you ask it. So it's okay. We are learning, as I said, but don't be deviated from the whole approach. Whenever you are starting the approach, follow it till the end. Okay. Just give me a second, Dr. Muhammad and Dr. Omar. I will pick up the phone, then I will be back to you. Okay. You can post your scenario, Dr. Muhammad, to Dr. Omar.
Okay.
Sorry, I'm back. You're done, Dr. Omar, Dr. Abdullah, Dr. Muhammad.
This is the scenario in the sheet.
Okay, 40 years old, Miss Nadia, complaining of backache and body ache. Take history, examine, and there's a concern. Okay, let's go back to the. You have any question, Dr. Muhammad? Sorry, because I interrupted your talk. Any
No,
question? Okay.
no.
Okay, anyone want to comment before reading quickly the chat box differential and comments? I think some of doctors wrote it downwards. Amyotrophic lateral sclerosis. If you mention motor neuron disease, it's more than enough. Please add, whenever you are mentioning motor neuron disease, you have to say against that there is sensory affection, which is against motor neuron disease. But it's classical manifestation of Kennedy disease. Okay? So at least mention the motor neuron disease. Whenever you are saying there is fasciculation in such age with family history, you can say this is motor neuron disease. No sensory, agree. No cranial nerve, agree in classical type. But there is some a typical case, which is Kennedy disease. Yes, kidney disease, Dr. Marwa, sorry, Dr. Riham Mansour, and the other, Alhamdulillah, okay. Dr. Al-Huda, the case scenario, thank you. Kidney disease, rare case, appear in UK, agree. It's not in overseas at all. It's not common disease in our Middle East. Dr. Riham, X-linked recessive, exactly. Okay. Whenever you're ready, Dr. Omar, we can start. By the difficulty of the case, the long, whenever it's difficult, the examiner will put the threshold of his judging higher than the easy case. So to have such case, he will tell you, yes, some approach to know the investigation. And once you mention motor needs, I think they can give you the good mark or maybe the full mark. So don't worry, even if you don't give the name, at least you are knowing the differential or the top differential or the second differential, and try to mention it's a mixture of upper and motor neuron. Don't forget to mention this patient is wheelchair for how long as well. The other neurological manifestation you have to mention while presenting the patient. All these things will give the examiner impression that you know and you are aware about the neurological manifestation of this condition now, even if you don't know the disease as it's very rare case. Okay, but it will not leave you, or it will not give you execute that you didn't ask about the systemic review, even as I said, one question for every system. Any chest pain, any awareness of heartbeat, any short of breath, any change of bowel habit, any tummy pain, any change in the water work, any muscle skin or skin rash or muscle pain or joint pain. You finish it within maybe 20 seconds.
Can you hear
Okay?
me?
Yes. And I think examination will be challenging. Cranial nerve alone will take 4 to 5 minutes. Okay, so if you will examine the cranial nerve, which cranial nerve you will choose? Dr. Muhammad.
5, 6, 7, 8. This is the most important, and 12 or 11 also.
Okay, if I give you one cranial nerve to examine, one only one,
For this patient,
particularly this patient and in general.
well, usually the most important 7. 7
Exactly. Why you would choose 7?
will differentiate between upper and lower motor.
Exactly, that's it. So whenever you have opportunity to examine one cranial nerve, do the facial examination or facial nerve examination. Not only that, it will show you any asymmetry in the face, and it will guide you in that upper motor or lower motor by the forehead spared. Okay, if this forehead is spared, this is a lower motor. If the upper motor, if the sorry upper motor, if the forehead spared, this is upper motor. If the forehead affected, this is lower motor. Okay, and also you can know the site. So the lesion will be away from the nerve lesion will be away from the asymmetry. So it gives you 2 marks, one for the affection, the level I mean, and the other for the side. Okay, clear now for all?
So shall
Yes,
we
doctor.
start?
Yes, we can start. Here you go.
Hi, hello. My name is Dr. Omar. Are you Mrs. Nadia?
Yes, I am. Miss Nadia, 40-year-old.
Thank you for confirming your age, Miss Nadia. Miss Nadia, it's been came to my attention that you are visiting us today for some backache and some pain in your body. Is that right?
Yes, yes, doctor. Since 3 months, I am suffering from this back pain and
Mhm.
this horrible body ache. I don't know what's happening for me. Started gradually and increasing.
Okay. I'll try my best to address your concern and your problem. So you've mentioned the back pain and the body ache started 3 months ago, 3 or 4 months ago?
4 months ago, yes.
4 months ago. Okay. And where is the backache exactly? Where's the pain? Is it
Part of my
in
back.
in the
And the lower part on my
lower
back.
part? Lower part. Okay. And other than this, since it started till now, is it increasing, decreasing, or it's been worsening or the same?
Yes, increasing. That's why I'm coming.
Okay. Is it there all the time?
All
Or
the time increasing by the time.
okay. And did it start in the beginning of the day or improve
Yes,
during the
start at
day?
the beginning of the day and by the day increasing more.
Increasing more. And has it affected your work, your daily life?
Yes, doctor, I am
I
taking
can.
some sick leave nowadays to make rest.
You are taking
Some sick leaves to be
sick
rest.
leaves. I'm sorry to hear that. Okay. And have you noticed anything that make it worse aside from the movement during the day?
Nothing, only my daily activity affected during doing my lunch for my family.
Yeah. Anything make your backache worse other than moving?
No,
No. Okay. Have you tried anything to control the pain?
for some paracetamol, but يعني some little relief, but again coming back.
It's not helping. Okay. And what's the can you describe the nature of the pain for me, please?
Yes, it is aching pain, doctor.
Aching pain. Okay. So on scale from 1 to 10, 10 is the most severe,
Started
1 is the
4,
lowest.
now 5, 6, يعني like
4,
this.
5, 6. Okay. And have you noted anything else other than the body ache and the back pain in the last 4 months?
So this body ache, I feel sometime my hand also some like spasm, cramp. I like this. This cause my pain.
Spasms and cramps. Okay. And do you feel the same around your back?
No, my back only the pain that interacting
Only
me
the
to
pain.
me. Yes.
Okay. And any pain in any other joints of your hands?
No,
Okay. And any skin changes you've noted?
no,
Rashes?
no,
No. Okay. Any hair loss?
no.
Okay. And any changes in your bowel motion you've came across?
Some loose motion coming, but I think for a while, not too much, not disturbing me.
For a while. Is
Not
it
too much.
during the last 4 months?
It's maybe 1 or 2 times only, nothing.
Okay. You don't get constipated at all?
No,
Okay. And how's your waterworks?
it's okay.
Okay. So you don't have any skin problems or pains in the joints, in any other joints other than your back?
No,
No. Okay. And what about your eye? Any dry eye?
my eyes okay.
Okay. Gritting sensation? Nothing?
What?
Any gritting sensation, dry eye?
No, no, no,
Okay. And any tenderness in your chest?
no,
Any chest pains at all?
no. But
Sure.
sometime I feel some heart awareness from
Okay,
a
so you
while.
have heart racing. Okay. And
But alhamdulillah, yeah, it is going well, nothing yet.
okay, have you seen anyone for that?
No, it come
It's
like a
not
brief with effort
free.
only.
Okay. Um, and you've told me that there is no shortness of breath,
No,
no difficulty swallowing,
no,
no tightening of the skin around your mouth.
no, no,
No. Okay. Or around your hand or anything. Okay. Any little changes you've came across?
no.
Okay. Before the 4 months, how was your health in general?
I was okay.
And you don't have any chronic medical problems,
No. لا,
operations?
sorry, I have diabetes.
You have diabetes. Okay.
But
Okay.
recently, it is not too much time. Only 3 years. I am a patient following my doctor and on my insulin. And last reading is okay.
Okay. Other than insulin, are you taking any other form of medications?
No. Only the
Aller
paracetamol for back pain. Yes.
yeah. Any allergies?
No.
Any family history of any medical problems?
Also, my mother same diabetes.
Your mother has same diabetes. Okay. No family history of any joint problems, any cancers?
No.
No. Have you noted any recent weight loss,
No.
fevers, not
No.
night sweats,
No.
change in your weight,
No.
any lumps and bumps in your body,
No.
weather preference,
No.
swelling in front of your neck?
No.
Okay, thank you for answering my questions. So it's just a quick question about what you do for a living.
I am accountant.
You're an accountant. Do you drive?
Yes.
Okay. And are you sexually active?
Yes. I am married, doctor.
Yeah. Okay. And it's since you are married, it's with stable partner. Then last thing to touch base with is about your smoking. Do you smoke?
Yes, doctor. I am a heavy smoker.
Heavy smoker since when?
10 years.
10 years. Okay. And you smoke 30 cigarettes a day, 10, 20?
10, 20 per day. Last 10
And
years.
what about alcohol?
But moderate intake, especially in the weekend.
How many units a week?
10.
10. Okay. Thanks for answering my questions. Do you have any ideas about what might be happening with you or
I don't
concerns you want to share with me?
I afraid some problem in my back. I don't know really what's happening. This is new for me.
Okay. So, just a quick question before examining. Do you have any weakness, any pins and needles in your hand, legs? Hello?
No, no,
No. Okay. Okay. Is it all right? I will be in better position to address your concern once we do the examination. I'll start by doing general physical examination, examining the hand. Is there any nail changes, clubbing?
no, normal.
Normal. Is there any muscle wasting, any tremors?
No.
Pulse is okay?
Yes, regular.
Okay.
80 per minute.
Okay. And any pallor when examining the lowering the lower lid?
Valor? Yes, there
Yeah.
is mild valor. You are right. Mild valor.
Mild pallor. Okay. And is there any obvious lesion in the mouth? Gingival hyperplasia,
Like what?
any gingival hyperplasia, any mucus, any staining in the mouth, any
No.
discoloration? No. Okay.
Only discoloration from smoke.
From smoking. Okay. Okay. And I'll examine the abdomen. Beforehand, I will examine the heart. The heart. Any murmur? Audible
No,
murmur?
no.
No.
It's 152, no gallop.
Normal. And chest is normal.
Yes, just as normal.
Back. I'll palpate the spine and the sacroiliac joint.
Tender, no
Tender.
scars.
From toward the base or the whole spine is tender?
To the base, and no scar, no skin changes.
And sacroiliac joint?
Sacroiliac? No. Okay. Only the lower part of the back.
Okay. And I'll examine the abdomen.
What
Any
you want?
superficial palpation, deep palpation,
Not willing?
or no swelling, yeah?
No tender, yes.
Okay. And no organomegaly?
No organomegaly.
No obvious scars?
No obvious scars.
And the patient is able to walk normally?
He can move, but he has this pain, so he's better not allowed to move. If you need to examine the left.
Okay. I'll examine quickly I'll ask him to raise from chair with his hand crossed to see if there is any proximal myopathy.
He can,
He
but
can.
after feeling I have pain in my back.
Pain in the back only. Okay. Um, Toward the end, do you have any? You've already answered this question before. No pins and needles. No. You are aware of of the sensation in your feet and in your hand.
Yes, I feel my hand and the leg is okay.
Okay. And I'll verbalize the ophthalmoscopy for as the patient is diabetic.
Nothing. It's 3 years
Nothing.
only.
Okay. Okay. Thank you for letting me examining you, Miss Nadia. Okay. Um, well, I think we need to run some tests, blood tests, to check for possible reasons for why you are having those those pains, and then after the
2 minutes left.
after the test comes back, we can look for what is the possible reason. There is few possibilities. Could be some inflammatory disorder that it's causing this uh, pain and turnus, pain and back pain and the body aches. If everything comes normal and we've excluded everything, um, it could be a simple thing like fibromyalgia, but beforehand, we can't think of anything at this time.
Is it something serious, doctor?
At this time, we will try to rule out the common things first and the dangerous things first. Um, so I don't think at the time being, from what you told me clinically, there is something to worry about for the time being, but we will look for potential causes for if the inflammatory disorders comes normal, we will do an X-ray of your back to start with. We will do also few imaging.
Okay, doctor. I changed my house last before this to another area with no sun there, very cold there. It is any relation for this?
Could be,
My period
could
is
be.
not okay nowadays. I feel it is changed. It was regular before. Nowadays there is some irregularity. It is not as usual for me. Any relation?
Um, your period is not regular, okay?
Yes.
And since when? Is that since the last 4 months?
Last 4 months, yes.
Okay. And beforehand it was regular.
Yes, it was okay, but gradually,
S-
last 3 months, 4 months, I started to feel it is not regular.
So I thank you. Thanks for sharing this with me. We will send a hormonal panel to touch base on that.
Okay, doctor, thank you.
Thank you.
Your positive finding, please.
Okay,
Today I
time is up.
examined.
Yes, start the examiner, please.
Yeah. Today I examined Miss Nadia, who presented with back aches and body aches with for the last 4 months. Her general physical examination revealed pallor, and but the examination of her body system didn't reveal any. There was no positive finding apart from the tenderness in her back, in her lower back. I would start ruling out the possible causes of her anemia. She shared with me toward the end of the consultation that she has moved houses and she had little exposure to sun. So second differential for that would be vitamin D deficiency. And she mentioned also this irregularity in her period.
So
Putting
your
all of
list
this
of
together, putting all of this together, first it would be vitamin D deficiency associated with anemia. I would look for malabsorptive syndrome. However, she didn't have any loose stool apart from one time or two times, as she mentioned. But this would worth looking to rule out possibility of celiac as a common thing, as a common cause of malabsorption. Also,
Did you
she
ask her,
didn't.
did she mention with a specific food or not?
Is that? No, I didn't ask.
But it is okay, you should rule out, right? Continue.
Yeah. Um, yeah, this is pretty much I can think of what I can think of.
Okay, what your management?
To start the management, I usually start with the investigating the patient from the bedside. And then I would start by doing full sets of observation, lying and standing blood pressure, urinary dip, and sending a stool sample if available, X-ray, X-raying the back, and ECG to rule out any associated arrhythmia with possible electrolyte imbalance. And then the routine bloods, including nutritional bloods of iron profile, vitamin D, and folate and B12. We will send, if I wanted to rule out malabsorption, I think sending the CTG at the time being, I will leave it for the discretion of the gastroenterologist. To manage her, it will be in a multidisciplinary approach. Importantly, to refer her for gastroenterologist after we have the investigations, and occupational therapist to review her her home, and to arrange for some possible changes, even change houses if needed, and to start the patient, of course, on active form of vitamin D and folic acid and B12.
Anything else?
Mm,
What about when she mentioned her spasm in hand and she
mhm.
has body ache and she has some heart awareness? Did this need any care from you?
We do initially in ECG, and we can put the patient on Holter.
Yes, yeah. And what does it mean for you? What is this spasm and what is the relation for our case? Okay, doctor. You mentioned
It could be.
for
Mhm.
the
I don't know, to be honest. Yeah.
patient it is inflammatory condition happen to your
There's a possibility that she
alright?
could, yeah.
Okay. خلاص I finished دكتور باسم.
You can comment, Dr. Muhammad, now. Yes, it's okay.
معلش يا دكتور عمر
No problem.
ببقى رخم انا شويه في طيب هو بس يعني my comment firstly your approach is good يعني you started by the complaint and relevant system then constitution started the rheumatology
Mhm.
family history and some social but even you didn't يعني when we reach the social this first thing يعني she is telling I am heavy smoker and I am moderate alcohol even you didn't يعني comment for her for the welfare at least to be on the safe side يعني on the time anything the patient positive need to give him immediately so the approach
Yeah.
is very good but the problem you touch and hurry away from the problem يعني he's telling you I have heart awareness you didn't tell when
Mhm.
يعني at least some details about this you feeling any dizzy you feeling
But,
any
Mhm.
about hand pain about hand spasm what this spasm you feel your finger you can explain for her you feel your finger like this خلاص you know that is carbopedyl spasm it is hypocalcemia any numbness around your mouth any tingling around your mouth خلاص you confirm this is hypocalcemia this is from the approach. The approach is very nice, but the problem you are touch and hurry, and positive, negative, you are hurry. This is the first thing. So we'll start from the beginning of the approach, and he told you clearly, I have back pain increasing by movement, gradual onset, progressive. Mechanical pain. And at the end, you told to the patient it is inflammatory, and you started to be more details for the inflammatory and rheumatology. And يعني I think maybe Dr. Bassem corrected me 2, 3 times or 4 times you are going to something away from the case. It is a mechanical. First, from the approach, mechanical or inflammatory. Once خلاص you confirm mechanical, you can touch the inflammatory fastly. Joint pain, some swelling, rashes, وفinish خلاص. You finish this inflammatory and concentrate on the mechanical pain. You
Mhm.
didn't ask her even trauma. She maybe have any trauma there. And after that, you touch the red flag about bowel motion and water work, but you didn't. You lost any control of this. This is very important to to save your time. Examine or not the lower limb. You told her, like any case, you have any problem in water work, you have any problem in uh, in bowel work,
Mhm.
and you didn't stress on any red flag there. Okay, so no asking about trauma and red flag. This is the ABC to go in the mechanical pain. Maybe you are confused about inflammatory or mechanical, but this is the approach. After that, when you خلاص comfortable, it is not emergency for you. No bowel or water, يعني no loss of control here or there, and no feeling weakness in her limb, no feeling numbness, no altered sensation. خلاص, no, we are
Mhm.
now called the case. So you will continue after that to continue this back pain and the analysis of the complaint. Then, it is a mechanical pain. Such age 40-year-old female, and she has back pain. It is not يعني maybe age of malignancy if there is constitutional symptoms, and you rule out no weight loss, no fever, no cancer. So no infection there, no malignancy there. You can put it at the lowest part of your then you will خلاص we finish now. No rheumatology, no inflammatory, no malignancy, no. خلاص, this is a female who will go to his back history. His past history, she's telling, I am diabetes, my mother is diabetes. Even you didn't ask her about the association for diabetes. she told you will control, but no problem to tell her any heart attack, any, especially she's telling you and I have a heart awareness, heart like this. So firstly, one question, how is your control and how you are following your eye, your heart, your like this, one line,
Mm-hmm.
one second, half minute, it will finish the case. But this is giving you, she's telling me and my mother have diabetes, so we are going with autoimmune, and she's telling I am on insulin, so this is type 1 or late type 1 to autoimmune, and she's telling you I have water. You can come back to her bowel work when she's telling you I have some loose motion, to ask her it is related to pasta, to anything. She will confirm on you or even not confirm. خلاص, this is celiac until proved otherwise. And you, mashallah, confirm on it in the judgment and in the differential. And to add to this, I need to rule out even no other symptoms. I need to rule out other autoimmune disease, especially when you have now some carbopedir spasm, some spasm in her hand, some body aches, yeah, going with hypocalcemia and heart awareness. So as a part of the autoimmune hypoparathyroidism, primary hypoparathyroidism. Come back to and this can cause also back pain. But the main case here, to ask her about her female history, period, pregnancy, miscarriage. She is telling you at the end, she tell you the key that she has irregularity and she was okay. And if you ask her, she has pregnancy and no problem. And this 40-year-old, she has started to lose her periods. And if you take more details asking me, she will tell you become more faint, no less blood like this. So it is a case of it is a mechanical pain for differential diagnosis. My first diagnosis in view of her period irregularity, it is osteoporosis due to premature ovarian failure. This is the case. After that, you can tell that she has this another autoimmune association, celiac disease, in view of her bowel work or loose motion. I need to rule out celiac disease and rule out pseudo hypopara in view of her carbopedir spasm and
Mm-hmm.
bony ache. This is the three differential for this case. It is a case of autoimmune problem, multiple autoimmune. And the message is that once you have diabetes, search for by even one question for all. You have any dizziness when you're standing, any tanning on your skin, Addisonian. You told some of them you have any rashes on
Skin
skin. Okay.
loss.
I,
Hair
I
loss. Sorry,
suspected
hair loss.
I suspected that she could that we are going to hemochromatosis in the first, but no, there's no skin changes,
Yes.
no significant bowel motion abnormality. If it's
Yes.
one or so to yeah, I'm sorry, yeah, continue, Dr. Abdul. No,
Yes. But hemochromatosis, Dr. Omar, يعني it would not rare to come with back pain. Rare. It can come with
it comes with back
hypoxia.
pain and joint pains,
يعني the
yeah,
main
and
problem.
diabetes.
Yes, you can concentrate. Usually when they bring the case, whatever the association there, but the concern and the judgment and everything will be on the complaint. She may be hemochromatosis by diabetes and hypogonadism like this, but the main complaint is the back pain. So you should rule out the most important causes for her mechanical
Yeah.
pain. يعني if you write the diagnosis firstly, you have the diagnosis mechanical pain for differential diagnosis. This is you will take good mark. Then he will wait for you to tell him from your history the positive data you have that what is the most provisional. And vitamin D deficiency, she's telling you another key. She has no sun, no exposure. And if you ask her about her diet, she will tell you more that I am restricting my diet nowadays to decrease my weight. So she has many causes for this. طبعا you rule out trauma, you rule out malignancy, the main sinister problem. Then you will go to the female. خلاص, this is a female. You will go for autoimmune as she is diabetes. Regarding the examination, you did it well. but you need طبعا carbopetal spasm. You need to confirm Tovestic and Trazocine, and you need to do for her lower limb. Even she is telling you no red flag. If you have time, at least one motor, one sensory, at least يعني to do any to confirm that the patient no no neuro emergency يعني for this mechanical pain. Regarding okay, we finish it. Also, as we mentioned, في another cause. She is telling you I am heavy smoker, I am moderate alcohol. This is another cause. You can do it in the list. Vitamin D deficiency due to low sun exposure, diet, heavy smoker, like this. Even you didn't touch it and you suspect vitamin deficiency, mention it. I will review her regarding her diet to see that you will follow this vitamin D deficiency. So, okay, regarding the investigation, as long no emergency and no red flag, خلاص, it is not emergency. We can send apart from the basic to see her anemia profile, full anemia profile, as you mentioned, from CPC, iron, vitamin B, folic, or this. ASR, CRP for any inflammatory. طبعا the most important على طول on time until I will send full electrolyte, especially calcium level. I will do for her ECG. I will do echo to check any prolonged QT to correct her electrolytes, even up to Holter as you mentioned. Second important as a specific osteoporosis or bone profile, calcium, magnesium, phosphor, alkaline phosphatase, vitamin D level, and other very important. I will go to the imaging, X-ray, then MRI. Don't tell X-ray alone. X-ray, MRI, also DEXA scan to confirm our diagnosis, minus 2.5 if not on steroid, or more less than minus 1.5 if on steroid. And this is important regarding the steroid and any medication. You didn't ask her, give me your medication list. Maybe she is on any steroid there. طبعا you asked her any other medication, she confirmed nothing. But can, especially in the diagnosis that related to maybe medication, osteoporosis can happen with steroid. So you can give me medication list on the time. يعني any other medication, please give me medication list. خلاص, because most of the in the exam there is a paper he will give to you to distract you by some medication or to confirm some diagnosis for him. So attach, give me your list, even tell you no other medication, right? Okay. طبعا I am confirming you are rolled out, and this is very good that you did it. You rule out malignancy by constitutional symptoms. You rule out myeloma by any increase in water. طبعا it will be against myeloma will come with hypercalcemia. It will not come with carbohydrate spasm. But this is very important to rule out. يعني the approach, as we mentioned, mechanical inflammatory, then any malignancy, then especially if then any inflammation, any infection طبعا. And this is very important. You didn't attach any travel history, any HIV, any يعني you didn't give all the risky behavior or travel history for any discitis or infective يعني for the back. Okay. The treatment, as you mentioned, will start correct calcium, give the vitamin D, bisphosphonate, follow up her vitamin D level and calcium level, and stopping that alcohol or decrease it to the minimum, and stopping smoking or risk factor, change his house, a dietitian to follow her diet, fertility doctor to check for any hormonal replacement for the premature ovarian failure. Especially if you ask her, I need to have a baby again. You should ask her about this. Very important also for the patient. So you should ask her about this. Besides طبعا from the beginning multidisciplinary, from also from doctor, from also occupational social support, all our multidisciplinary team. Okay. طبعا you will give her advice regarding heavy object and avoid any trauma, especially she is now high risk for fracture, and give her the red flag about if she feel any numbness. That was communication يعني, but if you
Mm.
have time. Okay, I finished, Dr.
Okay.
Omar. Your approach was very nice, but as I mentioned, you touched and
No,
didn't.
the critical miss would be the gynecological history. This is the
Yes, this
this
is
is
the take
my
home
this is
message.
my yeah this is my big take home message. But sometimes if you are fully speaking with a female, you would remember it. But due to dissociation between that you are
No, no,
usually during when you practice, sometimes you
it's
might dissociate the from reality. Like in reality, you would touch base on such a thing. Yeah.
no, no, no. Don't think so, Dr. Omar. Even in the online or not online, face to face, maybe with the stress you will forget everything. It's a
Yeah.
matter of training and to be remembering everything by heart. Okay,
Yeah.
so it's not because of this. Don't put it like this. In
No,
the
no, no.
exam, believe me, even the patient name you forget. So how to
Yes.
avoid the multiple practice training every day? The partner, of course, you have to go to have good partner who can remind you those things. Let's go back to the comment. I agree with Dr. Muhammad. What you miss here, the big differential, is it mechanical or inflammatory?
Mm-hmm.
Actually, and unfortunately, you went through inflammatory type. Okay, because you
Yes.
ask about other rheumatological manifestation or inflammatory causes. But the problem, this patient is having pain with movement. So you can say this is mechanical back pain.
Back pain. Yeah.
Exactly. So what I have to do here, I have to ask about trauma. You missed the trauma, right? You forget the trauma.
Yes.
You miss even throughout discitis, which is also one of the most important differential in mechanical back pain. You missed also the effort as disc prolapse or spinal stenosis. Whenever you are raising the leg, it can increase the back pain. You miss the neurological manifestation. Is there any loss of control over the bowel or water work? All the things you have to ask them whenever you have mechanical back pain. What are the top differential? As I said, multiple myeloma, and Dr. Muhammad also mentioned multiple myeloma in PACES. I'm talking multiple
Mm-hmm.
myeloma in the top, discitis, or TB infection, or space occupying lesion. At the end, you can say trauma, and they are not bringing patient with trauma as a definition, but you have to rule out the trauma. Spinal stenosis, disc prolapse, all these can cause the mechanical back pain. Don't speak about the other cause of ankylosing or inflammatory, whatever the case is. So you are talking about mechanical back pain. Put your differential in this group. And you can
Yes.
say to the examiner, I have patient with mechanical back pain. He will be impressed with this answer. What are the differential? Whatever you put, he will accept. However, you are putting the differential of mechanical. So don't tell him
Mm.
in mechanical differential
And
differential of
put
mechanical.
inflammatory.
Yeah, inflammatory. He
Yeah.
will say, yeah, this doctor doesn't know what he's putting for differential.
Yeah.
What you miss here, and this is the importance of the systemic review. I'm always focusing on this point, the systemic review. Why it's important? Well, because it reflects this part of the history. If you miss the female history, which is one of the systemic review question, you might miss the case. Here you miss the female history totally. The
Mm-hmm.
periods here was irregular, so you couldn't know this is premature or. However, you ask about the hair loss, which is good question. No one is remembering this part of the history, particularly in the female. As you know, the
Mm.
female in such age, childbearing age, they are very common to have the autoimmune association or autoimmune disease. She had one of them, the diabetes, okay, but you didn't screen the others. Yes, the skin loss one, oh sorry, the hair loss one of them, alopecia areata, but still the other autoimmune manifestation you didn't ask, like
I
celiac.
asked about the skin rash
Yes, I
and
agree. You ask about
yeah
skin, but the hair loss as well. But here the important to ask the celiac. When he mentioned to you the diarrhea, you just give one question for the diarrhea. For how long? And you didn't know what the type of diarrhea.
Uh, But he told me that that she had diarrhea just only twice, which is anyone can have diarrhea in his life twice. Usually, if they want to point you toward the
Yes,
like to put a hint,
yeah.
like it will be
It will
diarrhea,
be
it will
more
be problematic.
frequent. Yes.
Yeah, it will be
Okay, I
problematic.
agree with this point. Supposed to have a frequent diarrhea to say this is celiac, or
Hmm.
to make it more relevant, so you can analyze it more. But the take-home message here: whenever you have positive finding, don't ignore it. Don't say, "No, it's 2 days only and it went." No, you have to know why he had or she had this diarrhea. Three question at least. For how long? Okay, onset, course, duration, and some specific relation to food. Like, do you have, or do you think it's related to the food? Here, I think, Dr. Muhammad, it could be related to the food, right? So
Yes, Dr.
pasta,
Fahmi,
pizza.
if he asked, if he tell me 2, 3 times, she will tell I have a pizza, then I have this.
Yes, see,
Yeah.
because it's related. Whenever you have diarrhea, Dr. Omar, in your exam,
Mhm.
related to the food, either celiac
Yeah.
or roll out celiac.
I think we can think of a quick question that would cover everything. Like, do you think it might be related to something, or do you
Yes,
think anything provoked this diarrhea? That
yes,
this is the
exactly.
take-home message. Like, because in such a case, if you stop on everything, you would lose the time.
No, no,
Uh,
no. You have to stop because it will be positive for some reason. It's not there because of no reason. Diarrhea here is a clue. So you have to know why. Is it related to something autoimmune like celiac, or is just something related to infection like traveler? Don't skip it. Okay.
mhm,
Don't say no, no. It's not important. It was for 2 days, then disappear. No, you have to know what provoked it as a complaint. Okay, because you are analyzing the complaint, but it's not. It's necessary as well to ask about anything in the positive, in the finding in the history, even previous 3 months or related to the complaint. So you have to know, is it related or not, to analyze it, to rule out something it might be hidden. Okay, I think this is the only clue in the whole scenario: the diarrhea and the female history. Not only
the female
female.
history I missed. I do agree, which is a very big take-home
Yeah,
message.
yeah.
And thanks for Dr. Abdul to brought
Okay,
this scenario. To be honest, yeah.
okay. We ask you, what are the female history you have to ask in 40 years female?
Um, First of all, you've mentioned that you are married. Usually, this is the logical way. Are you sexually active? She will tell you, I'm married. Any children?
Okay,
She will tell
let
you
me
yes.
correct one point here,
Oh,
because you
okay.
ask her, are you married? But
Mm-hmm.
and you told her, okay, so you don't have other relationship. How do you assume that? I heard you saying that, right? So since you are married, so you don't have another partner. No, it's not necessary. So you have to ask, are you having any casual relationships? Because not all of the marrieds, particularly there in UK and in the Europe, they are married, but they might have casual relationships. So you have to specify a question, even if she has
Yeah.
or he has single partner, he had, or sometimes they have occasional casual relationships. So I have to roll out this question not only by pregnancy, or sorry, by
No,
a partner. Yeah,
sorry,
okay. Tell
sorry,
me.
Dr. Bassam. I didn't say I will rule out this by this. I said that usually I would start the line of questioning by, are you sexually active? She would tell you yes. Are you married
Okay,
or you have a stable partner? Yes. Do you have children? Yes. Are you on any pregnancy or
okay,
method? She would tell yes or no. When was the last
perfect.
period? That's it. This is how I
Yes, yes. They are collecting them in three P's. Okay, let me
yeah,
summarize and make it very easy. Three
partner.
P's.
Yeah.
No, not partner. Pregnancy, pills,
Period.
and yes, period. These are the three P's. The very important you have to ask. The other, like partner and casual relationships, this is for this HIV and risky habit. Okay, you can add them together in the same, but the three P's are very important. Are you pregnant
Yeah.
by any chance? Any birth control pills? And how is your period? Every question for them will give you and will guide you to something. Let's say about pregnancy. Are you pregnant? Do you think any disease in PACE is related to the pregnancy?
Any disease
Okay, I will give you
related to
example.
pregnancy? No.
Yeah,
No.
I will give you example. Carpal tunnel syndrome, for
Yeah.
example. Yeah,
Yeah.
so, maybe abdominal distension, amenorrhea. So pregnancy can give you a clue if this patient amenorrhea because of pregnancy. Yes, she might tell you, yes, doctor, I didn't do the test, but you can put it as a differential. It's one of the examples. I didn't mention all of them, but I'm just giving some examples. Let's go to the birth control pills. What do you think the importance of this question? What if the patient on birth control pills? What the matter?
It could be for treatment, or it could be for
Yes, I mean, what the relation between OCP and some disease in PACES? What do you think?
the VTE, the
Perfect.
thromboembolism.
From
Yeah.
thromboembolic, yes.
Yeah.
And cavernous thrombosis, venous thrombosis, DVT, PE, all of them can be related to this medicine.
Mhm.
Okay, even last week we discussed hepatitis related or cholestatic
Cholestatic.
cholestasis
Yeah. Yeah.
related to the birth control pills. Not only that, you might have a lot of them, but I'm giving example. Okay, let's go to the last one, the period. What do you think the question or what the idea will give you behind the period? If you ask about
Uh,
the period, what could be
the
yes,
axis, the pituitary ovarian axis.
yeah, access
Uh,
failure. Okay,
yeah.
what else?
If it's recently stopped, then the patient could be pregnant, and you need to verbalize
Exactly.
pregnancy
Yes.
test on the bedside.
Mhm.
Um,
So either increase or decrease
hormone.
the
Yeah.
exact, yeah. So,
Uh,
oligomenorrhea or
in
menorrhagia,
if
thyroid,
menorrhagia, you will think, huh? Yeah, thyroid. Yeah.
thyroid in the top of the,
Endocrinology. Yeah.
yes, either the change or absent. Absent means either pituitary or ovarian or thyroid sometimes, but thyroid usually give you either scanty or mini. So what I mean, the three questions are very important in the female child age or in a child bearing age. In any female in this age, you have to ask the three P's. The casual relationships, if you suspect HIV or any risk habit or infection, something infectious can be transmitted through the partner. And that's it. This is one of the systemic review parts. And you have, for me, you have to go through all these questions in every case. Even one question can give you a clue. Okay.
Mm-hmm.
But in the top of your priority to know the joint pain, what is it? What is the nature? You ask all the question, but I think also you miss the radiation. Where does this pain go? Did you ask? Is it going up,
No,
going
no, I
down?
didn't. No, I didn't ask.
Yeah,
I
yes, this is
remembered it.
also
I
important.
didn't ask about it. Yeah.
You ask about the scale, which is very good. And you ask about, you didn't ask the trauma and the radiation. That's it. This is what I can add to your approach. Otherwise, you are doing perfect. I just try to practice more before your exam. I know that it's very near, but try to
Yeah.
practice more to know and to pick up the most common cases coming in UK. Okay.
Yeah.
You have any question or comment you want to add?
No, it's the gynecological history is
Yeah.
important, not to be missed. The um, the other
Any
thing is
complaint,
that
any finding in the history, analyze it. This is another take home message. Any complaint, any finding, like I have cough. Don't tell him, okay, and are you okay now? Yes, I'm okay. What about the cough? You got my
Mhm.
point. So I have to analyze the cough. The cough, is it dry or with a phlegm? With a phlegm, doctor, tell me the color, tell me the amount, tell me the frequency. Here, the diarrhea, is it flushable? Is it related to the food? Is it watery? Okay, you have to know more about anything positive. Don't just overlook it. It might give you a clue or you might miss the case at all.
Mhm.
This is the two take home message today. Analyze any finding and don't miss the female history in any female in the childbearing age. Okay, you have any comment you want to ask or to add?
No, I don't think so, no.
Okay, thank you, Dr. Omar and Dr. Muhammad, of
Thank
course,
you.
for the case.
Thank you.
Let's go quickly to the chat box. Yes, I think yes. I was wondering, Dr. Ayula got the case osteoporosis in celiac disease from just some points in the question. Dr. Ihtisham as celiac with osteomalacia
Yes.
could be spinal stenosis, rheumatism. Okay, Dr. Ihtisham diarrhea wasn't not taken in details exactly, and also no details of hand spasm. Yeah, okay. So also one of the important, the awareness of heartbeat. He told you slowness, right? He told you it's slow. You can also ask more. Is it related to effort? Is it with rest? Anything positive? Again, even two questions to know more about it. It's fair enough. At least two questions, but don't ask one question and skip it. You have to ask at least two questions to know more about it. Is it related or just distracting? If distracting, forget about it. If related, put it in your paper and link it to your case. Dr. Ihtisham, hypocalcemia and tetany, agree. Pregnancy history, yes, he missed. Nice case, yes, I agree. Dr. Hisham, what is the final diagnosis? Premature ovarian failure complicated by osteoporosis and hypocalcemia. By the way, Dr. Omar, what do you think the calcium level in osteoporosis?
Yeah, the calcium level in osteoporosis would be normal.
Exactly, yes. But the hypocalcemia can worsen the osteoporosis, right?
Mm-hmm.
Okay.
Yeah.
Autoimmune syndrome. I should ask about pins and needles, Dr. Amal. Sensation to rule out pernicious anemia. Why you said anemia? You have to have finding for anemia like pallor or dizziness or tachycardia, but you cannot say anemia here. Okay. Why hypocalcemia? We mentioned due to tetany. She had tetany at the manifestation of hypocalcemia. Yes. Why she developed? Because of the celiac association. Three P's, Dr. Hisham, pregnancy pills and periods. Four P's, Dr. Hisham, add one more. Fourth P as partner. Yes, okay, you can put it as partner, but I usually ask partner with HIV question. You have partner? Yes, doctor, I have. Sorry for this question. You have any casual relationships? No, doctor, I don't have. You can ask about other risk habit. At the same time, any needle or shearing needles, any breaking, tattooing, blood transfusion. If you suspect HIV or some infectious condition, APLS side effect of pills. Of course, you can ask antiphospholipid. Yes, it's very important question. Thank you, Dr. Hasham. The miscarriage. Whenever you have suspicious of SLE, add to your screening miscarriages. If you have any miscarriages, and whenever you have delivery or baby, you have to ask what is the last baby age. Dr. Omar, what do you think the importance of this question? If you have baby of 6 months and patient is coming with constipation,
No, postpartum hypothyroidism.
okay, but so
Yeah.
you know it.
Yeah.
Perfect. Thyroid. Okay, one more question. If you have patient, the child is again 6 months and patient presented with short of breath, tachycardia, awareness of heartbeat.
It's the same. The postpartum what it's called. I forgot the exact name.
Actually, it's not postpartum, it's called peripartum.
Peripartum, yeah. Peripartum
Cardiomyopathy.
she will be having, yes, hyperthyroid cardiomyopathy, but why she's hyperthyroid, this is what I meant to
No,
answer.
no.
Yeah,
Hyper or hypothyroid, the same condition,
the same
postpartum
condition.
thyroiditis.
Yeah.
Postpartum thyroiditis, either hyper or hypo, or
Hmm.
even euthyroid. I'm talking about heart failure symptoms. So you have what's called peripartum cardiomyopathy.
Cardiomyopathies. Yeah.
Okay, perfect. Dr. Ala, putting premature ovarian failures as cause of menopause treated osteoporosis related to osteoporosis, we have to go through other symptoms like hot flushing, pain, erythema, hair loss, mood added to female history, diabetes, celiac as differential for autoimmune differential. Isn't yes? Absolutely right, Dr. Ala. You have to do more analysis about that if you suspect it. However, it's not very common.
Yes, yes,
Yes.
it was in the case also.
Yeah, exactly. Dr. Ala already wrote it.
Should ask about hot
Dr. Ala.
flushing and hot flushing at least. Yes.
Yeah, but that's why I'm trying to link the things together. Don't stick to one differential. The problem is Dr. Omar was deviated away from the mechanical. That's why he thought
Yeah.
about, but it's okay with the, you know now the case, and you can also remember it whenever you have it. Dr.
Mhm.
Aman, I mean, as a part of autoimmune, patient has some pallor. He said, you said pallor, Dr. Muhammad, in this scenario?
Yes, yes,
Yes.
there is
Yes.
mild pallor. It was there because of she has strict diet or pernicious anemia. But I rule
Okay.
out pernicious when he asked me pin and needle, and I rule
Yeah,
it out.
yes, he asked. I agree. He asked about that. So
I
it's
tried to make it about diet, Dr. Bassem. I wanted to ask about diet also.
perfect. So it's valid point, Dr. Amal. It's there. You have to ask about whenever you suspect it, ask about it. By the way, there are multiple association as autoimmune. If you can remember the all, it's better. If not, at least pick up the most common one. Okay. Patient had pallor in exactly. Okay, sorry, I didn't hear this part of pallor, but patient was having hypo or sorry, bradycardia. So I cannot say this is anemia because of the bradycardia. Usually anemia comes with the tachycardia, uh,
No,
chronic
we
heart
didn't
failure.
tell slowness, Dr. Bassem. I told I feel heart awareness only. No, not slowness.
Okay, okay. Also, I misunderstand it. So it wasn't low, it wasn't high, only awareness.
He
What
didn't.
you
He didn't. He didn't
he didn't
analyze.
analyze it at all. Okay, if we analyze it, okay, back.
But
What was it?
I asked since when for
Yeah,
the
yeah,
I didn't analyze the diarrhea or the episodes of diarrhea.
yeah.
But I asked only one question for the
Yeah,
for
one
for
question,
the
but you have to know more. Is it fast or slow? Not only awareness. What type of awareness he has? Is it fast or slow? At least, or regular and irregular. Okay, regular, fast or slow. And if he said, I don't know, you can tap on the table just to show him something mimic to it. Okay, you can tap on the table like a regular one or regular. Clear, Dr. Omar? This is the
yeah.
way how to analyze any awareness of heartbeat. Is it fast or slow? Is it regular or irregular? If he said, I cannot understand, you can tell him or you can tap on the table in front of him. He will tell you, yes, doctor, like this, or no, like that. Okay. Anyone, any question else, Dr. Muhammad and Dr. Omar first?
No, no. Thanks, Dr. Bassem. Thanks,
No,
Dr. Omar.
Dr. Abdul, I just wanted to remember something. When I assessed the pulse, you said it's regular.
Yes, it was regular. It was regular, but يعني
Mhm,
the problem during any patient significant symptoms like heart awareness, as Dr. Bassem mentioned, you should ask him it is fast or not. Maybe she has episode, any electrolyte disturbance, and you mentioned in the management, you told I need
mhm,
to do ECG to see any and electrolytes for any electrolyte disturbance. Usually, electrolyte disturbance, the patient will not all the time has the heart problem. He will have some episode with some effort, with يعني any change in his daily life. He will feel sometime he has some palpitation, some heart awareness, maybe some tachycardia with this anemia, with this hypocalcemia, especially if he's still not severe. If he has severe hypocalcemia, he will come in tetany in front of you. He will come in fits. He will come in seizure. He will not come walking to the clinic or like this. So in this case, as we mentioned, it is a case for to remember ourselves for the autoimmune collection. Once you
Mhm.
catch one of them, you have to roll out most of the. And when you, if you feel it is related to the complaint, you should search where بقى the source to diagnose the patient. This is you confirm a mechanical pain, and she have some spasm in her hand, so there is hypocalcemia there. With this anemia, there is maybe celiac, maybe pernicious, maybe يعني many clues there and some diarrhea. Many clues there. I push it that there is some autoimmune there. But you, unfortunately, you forgot the vagina or female history. But from the beginning, as Dr. Bassem mentioned, you miss the mechanical pain. So you take a track for 3-4 minutes away from the patient. Once you have a mechanical pain, osteoporosis, this is one of the, I think, one of the يعني, favorable cases in the basis,
Yes.
osteoporosis, especially in female patient. And he can guide you another way. He can tell you, I have my weight increased the last few months. He will take another to the weight gain cases. So
Exactly.
he can take you hypothyroid cases. He can take you يعني any way in back pain is a very favorable case in
Yeah,
the
it is very informative about the
yes,
and mind refreshing about the mechanical and
you,
about the and the inflammatory or the autoimmune causes.
you know,
But
Dr. Bassem, I bring it for me myself because all of us will miss the hypoparathyroidism. He can take
uh,
the kid as a pure hypoparathyroidism and can take another association with it. So once you
but
have diabetes, family diabetes, and some anemia and some, يعني you can guide you anyway. If you tell her you have dizziness when you stand up, she will tell you, yes, I have dizziness. You will check for, and you check for any tanning, I think, in the mouth like this. So I catch it. I saw this, خلاص, you rule out the Addisonian also. So, because if the case be your autoimmune, خلاص, he will not forgive you for forgetting the association يعني for this. Okay.
Yes,
So
but
Yes.
usually for osteomalacia, for it's if they want to bring it as osteomalacia, I don't know about the overseas centers, but usually it will be with proximal weakness.
Yes, yes, you're right.
And I asked for the proximal weakness assessment and it's been ruled out. So
the
I've
case
been thrown away for a second.
osteomalacia, Omar, Dr.
Hmm?
Bassem, this is not osteomalacia. It's not
Yes, I didn't
osteomalacia.
say osteomalacia, it's osteoporosis.
Yeah, if it's
Osteoporotic, not
osteoporosis,
only
yeah.
osteoporosis, it's osteoporotic fracture, Dr. Omar. Osteoporosis itself will not give back pain. The
This
osteoporotic
can
fracture.
be hypoparathyroidism.
Mm.
This is not osteomalacia. Osteomalacia, you put it
No,
as a third line.
so the
Right?
diagnosis, no, but the diagnosis for this case, it's been said that it's hypo
Osteoporotic fracture with celiac.
with
Celiac,
celiac.
yeah.
Okay.
And the celiac itself can cause hypocalcemia.
No, but through vitamin D deficiency. So the patient need to be vitamin D deficient in order for her to develop hypocalcemia. So I've
Not necessary to have osteomalacia without. So you can find either this or that.
yeah, yeah.
Even calcium absorption is something to be directly affected with celiac. It's not only through vitamin D, right?
Yes, calcium and iron is
All of
absorption
the
is from
elements,
the
yes.
beginning. Yeah.
Yeah, all of them will be
And
affected,
you
not
can
only by
mention
this.
osteomalacia induced by all the hypocalcemia, but it is not the first because this is a case of 3 months only. She started to have this premature ovarian failure. This is the main cause, and the hypoparathyroidism, multiple autoimmune polyendocrine, you can mention like this. But the main issue is osteoporotic
Mm,
bending
Auto for the for polyautoimmune
Glandular,
endocrinopathy
yes.
syndrome,
Mm.
yeah.
Mm.
Type 2 comes with hypercalcemia. Type 1 comes with hypocalcemia due to hypoparathyroidism. So I didn't think of it here because the calcium, if the calcium is high, it will be high as an association of Addison alongside with that. But this is too bookish thing to sophisticated thing for the APS type 2. But usually if there is diabetes, vitiligo, celiac, the autoimmune group, yes, you are right. I do agree. Yeah,
now, as
it
we
needs
Okay.
to be
mentioned,
ruled out.
Omar,
Yeah.
You have it's a must to have Addison if you want to say this is autoimmune
yes,
polyglandular.
Yeah.
Yes, you must have addition. And you can, as we mentioned from the beginning, it is a mechanical bit for differential. He will not, خلاص, he will, once you
Yeah.
tell him this, he will listen to you how you will enumerate your differential. It
Yes.
must be osteoporosis because of premature failure. From the history, there is new housing, there is low sun exposure. I will put vitamin D deficiency. I will put also celiac in even I didn't full history, take a full history. I will send for here celiac, thyroid. You can all this. He will not tell you no because many cases with autoimmune, he will start by diabetes. 10 years, he will fulfill full the autoimmune. Okay, he will start by hypoparathyroidism or hypothyroidism, then he will fulfill all the autoimmune,
Yes. Yes.
polyglandular or autoimmune. So he will not tell you why you send the TSH, why you send celiac. And in my approach for myself, once I have autoimmune, in my judgment, I will tell I need to rule out all the autoimmune. I will send
Exactly.
cortisone, thyroid, anti-celiac antibodies,
Yes.
like this.
Person who is screening. Yes.
3 screens or 4 screens, he will be happy. The examiner that you are know that you know that this patient sooner or later
Is at
will
risk. Yeah.
have this condition.
Yes.
Okay,
Yes. It's screening for all autoimmune. So it's not only what you have right now. All of them might come either together or later on in different timing. Okay.
So this is an osteoporotic case of mechanical explaining the mechanical back pain.
Yes.
Yeah. Yeah.
Yes. Again, osteoporosis itself, it will not cause back pain unless it's
It's an
fractures.
osteoporotic fracture. Yeah.
Yes, so please be sure that you ask about trauma or lifting heavy object. It might be the trigger for the fracture, but most of the females they will have osteoporosis but without pain. Once they have fracture, they will have severe pain. Okay.
Mhm.
by the way, Dr. Bassem, this is a very common case and very
Yes, yeah, I
famous.
agree. I agree. Agree
يعني
totally.
many
Not
cases in
only
our
not
family, you know, in our family, he maybe has osteoporosis, actually, we don't know.
every family member in after the period or in after the menopause they might have the osteoporosis. Now, let's talk about the risk habit or the causes or the triggers of osteoporosis. Dr. Omar, give me the causes of osteoporosis, or let's say the risk. Whose
No,
patient are risky to
in
have osteoporosis? I
the
mentioned one of them,
thin
menopause.
BMI,
Okay.
yeah, the low BMI, diabetic, smoker,
Okay.
um, low
What
BMI, diabetic, smoker,
what
and
else?
old, yeah, of course.
Old, yes, after menopause. What else? Someone can write.
Uh,
Yes, we
Alcohol,
mentioned low body mass index. Alcohol.
low
yeah,
All
yeah,
the lifestyle, sedentary lifestyle can cause it. Smoking, alcohol,
steroid and autoimmune
diet,
patients on a long-term steroid.
steroid, the diet habit. Okay, low body mass index, as you mentioned. Even the hormonal deficiency, as postmenopausal or some patient with low testosterone. Okay, all of them can be
In
having
men,
this.
yeah, this would be in males.
In males, yes, it happened in
Uh,
Klinefelter, for example.
yeah,
If they have lacking of testosterone, they will have this. Okay, some medication also can cause. So you can
the way
say,
Dr. Bassem, even in this differential, he can put in the
mhm,
differential. I need to rule out also menopause, and maybe started menopause, not premature renal failure. It
yeah,
will be reflected in the full hormone if it's HLH, and this it will be clear, yeah.
yeah, yes. So at least you mentioned the hormonal assay. Don't leave it without a screening for hormonal assay. Okay. Thank you, Dr. Muhammad. It's really a very nice session as usual. Postmenopausal, Dr. Ahcham, inflammatory arthritis like rheumatoid and ankylosing. Because of steroid, you mean? Yes. Steroid, always you have to ask about steroid itself as a medication, as Dr. Muhammad mentioned, as a medication, not only medication list, any medication called steroid you are on or you are taking for any reason. It can be the cause without, if you don't ask about it specifically, you might have it. Okay, Dr. Ahchan, it's without steroid, it's not that common, but okay. Steroid will make it more apparent. Okay, anyone has a comment before ending the session? We did a nice informative one today. Two cases were okay. And yeah, the take home message, as usual, systemic review, I believe it's very important to go through. Don't overlook it or postpone it. You can postpone it, but don't skip or overlook it. Okay?
Mhm.
Female history, as usual, is very important
Yeah,
in the childbearing age. Yes.
yeah. Dr. Wasim, I just wanted to comment and
Yes.
yeah, yeah. I think that I mean, considering everything in detail, and if you take it as a whole case, if we only say that this patient has a premature ovarian failure with osteoporosis, I think that will not be a complete diagnosis. So I personally feel that if I would have been presenting, so correct me if I'm wrong, I think it would have been appropriate to say that this patient has a celiac disease, most likely has a celiac disease complicated by premature ovarian failure and osteoporosis. I think that will make, because if you will only say premature ovarian failure with osteoporosis or osteoporotic fracture, then it will be difficult for you to explain why the patient is having spasm of the hand, because you will not be able to explain that
Yes, you're
what is the
right.
reason. Yeah, so it has to be a composite diagnosis covering all the things, and not only, I mean, yes, then the examiner, if you don't say anything further, then they may ask you what you think could be the cause. If you think it is a celiac disease, then what could be the cause of this back pain? And then you can expand on that further. The pain could be due to osteoporosis, which there
Yes.
could be osteoporotic fracture, and the second differential could be osteomalacia. However, this patient does not have any proximal muscle weakness. So I think I feel that this is more appropriate rather than saying that this patient has a premature ovarian failure, because then they will ask
Okay.
why you think that this lady
Exactly.
has a premature failure, and then at the end you will come to the celiac disease. So it is better that if you give a composite diagnosis at the start and explain that what's happening, because there has to be a reason in someone at the age of 40 years to have a premature ovarian failure and a
Okay.
secondary osteoporosis. So that's I feel is more appropriate anyways.
Okay. Let's say and clarify it. If you want to say celiac associated with premature, it's not complicated by. Okay. So as autoimmune, all of them comes as association. Premature, autoimmune hepatitis, celiac, thyroiditis, Hashimoto, whatever the case, but it's not complicated by celiac. This is the first point. The second point, yes, you cannot diagnose premature only from the history taking. So you are suggesting, you are not saying this is a case of, you are saying this feature suggestive of no one can diagnose without the investigation, right? And the scans. So you can suggest and tell him, I suggest this patient is having one, two, three, based on what, in view of what. You can say at the end, yeah, putting this together, I suggest this patient is having celiac associated with premature ovarian failure, and the complication happened because of celiac, hypocalcemia, and the osteoporosis also there. Osteoporosis and complicated by osteoporotic fracture, for example. So it's not target, or you cannot say it's detected diagnosis, it's suggestive diagnosis. But premature, I don't think it's a clinical diagnosis. You have to have some investigation, particularly hormonal assay. Okay. I think we can, but yes, it's not to say premature complicated by osteoporosis. You can say it's related to the association with premature as celiac disease. Okay. Anyone want to add any?
But this
Yes.
the case mechanical pain osteoporosis
Okay.
superficial pain اللي
Okay.
هو البوزيتيف هيستوري اللي هو اتاكد منها لو
Exactly.
خدها
Yes.
هي
That's
بريماتيور وفي هايبوباراثايروديزم انتوا يعني انتوا مسليدنج يعني ده هايبوبارا ده يعني
hypopara as
hypocal-
autoimmune. Okay.
yes
Hypopara
yes
as
he has
autoimmune.
hypobara
Okay. Yeah, it's not celiac. You want to say
yes not
it's not
celiac the
celiac.
celiac is last thing يعني last it is not
Okay.
the
So
case
a case of
the case
differential.
the
Okay,
case
I
was
got it now.
premature and hypoparathyroidism this is
Okay.
the main
Okay. Okay. خلاص. Well, I misunderstood it. So it's again hypopara. associated as autoimmune with premature, and also you might have also celiac in this patient. But the main differential, by the way, Dr. Omar, if you mention mechanical back pain, you might get the good mark.
Yeah,
Yeah,
Because
okay,
after that,
yeah,
this is
whatever your differential, he will accept.
yes,
And
yes,
even as we mentioned, vitamin D deficiency, as a balanced diet,
yes,
sun
yes,
exposure,
yeah,
smoking, alcohol. He give you four causes for vitamin D and for osteoporosis and osteomalacia. You
the
can put
but
whatever the
this,
differential.
yeah, yeah. But so it is a mechanical
yes. This is
back pain,
yeah.
and beyond that, to be honest, from the history, it is difficult, I think, to jump for hypoparathyroidism. Um,
Again, it's
uh, from I think, but the take home message is mechanical back
exactly.
pain.
Yes, hypoparathyroidism also you have to have hypoparathyroid hormone and hypocalcemia as well. So it's something
Oh,
suggestive.
there is a clue, Dr. Bassem, that
Exactly.
there is,
Yes,
he's
from
telling
the
I have a
history.
spasm in my hand. It is
Okay. Yeah.
in basis, the spasm mean there is tetany.
Yeah. Exactly. From the history, as you said, from the history as well.
Hypocalcemia, yeah, for possibility, yeah, yeah.
Yes. Okay. Thank you, Dr. Muhammad, Dr. Omar. Thank you, everyone, for the attendance.
Thank you.
Thank you, everyone. I don't want to miss anyone because all of you are great today.
Thank you,
The session
doctor.
was informative. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu
Assalam.
alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam. Thank you.